This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code MyDPCStory. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care allows me to be the family medicine physician I always dreamed of becoming, while also putting medicine after my family and my life and having a nice work-life balance. My name is Dr. Clodagh Ryan of Cara Direct Care, and this is my DPC story.
Dr. Clodagh Ryan is a board-certified family medicine physician. She grew up in Ireland and graduated from Trinity College Dublin Medical School in 1999. After working in primary care in Ireland for a few years, she moved to the western suburbs of Chicago, where she completed family medicine residency at Adventist Grange Memorial Hospital and spent 8 years in a private insurance-based practice. As the medical landscape became more difficult for the independent family physician, her disillusionment with medicine grew. She switched to direct primary care, opening Cara Direct Care in 2017. Dr. Ryan also serves as adjunct faculty and preceptor at Chicago College of Osteopathic Medicine in Downers Grove, Illinois, where in 2020 she developed the virtual elective Introduction to Clinical Practice with Telemedicine. The elective includes instruction on the U.S. healthcare system, health insurance, and the corporatization of medicine. Dr. Ryan spends her free time playing Irish music on the concertina and fiddle with her husband and her 4 children, who are also musicians. Her other hobbies include running and reading. Welcome to the podcast, Dr. Ryan.
Thank you, Dr. Concepcion.
It's such a pleasure to talk with you. And you and I have seen each other in person once, but we've talked many times apart from this podcast. And one of the things that you have said publicly is that DPC is the most fulfilling way I've been able to practice medicine in my 20-year career while being a wife, mom, and musician. DPC allows me to have a life while still being the best physician that I can be. And so, just tagging along with your intro statement, I wanted to start with your journey into medicine. So can you please tell us about how it was growing up in Ireland in terms of your care, your family's health care, and what pushed you into becoming a doctor?
So I grew up on a farm in the north of Ireland, and I am number 6 of 7 children. My dad left school at 14. He was taken out of school when his father died and had to run the farm. So my mom did go to college. She was a kindergarten teacher for 40 years. And the big thing for us as kids, we were pretty smart. book smart, was that my parents wanted us to go to college. There was no expectation of becoming anything in particular, but my dad did always have this idealized version of medicine because his father's brother, Dr. Daniel Boylan, was a family doctor in the early 1900s to 1920s or so, very close to this bridge that I have in the picture behind me here on the north coast of Ireland. And my dad would tell stories about Dr. Dan doing house calls and getting paid in, chickens or eggs or whatever. And he also would go out on the boat to Rathlin Island, which is about 5 miles off the coast where you're in my picture behind me here, to deliver babies in the middle of the night and stuff like that. So that was the idealized version of medicine that I saw. And to be honest, I didn't really want to do medicine because I didn't want to work that hard. I tried to find something in science that would fulfill me, but medicine just, seemed like it would keep me interested for longer and longer. And I'm really glad that I did, because there's always a fresh challenge and there's always something new to look up and to be interested in. So I was the only one who went into medicine, and I ended up as a kid, I was part of the NHS system, the healthcare system there in Northern Ireland, because that's part of the United Kingdom and still is. So we had socialized healthcare. We could see our doctor pretty quickly. It was very, very short visits. Oftentimes you would see the nurse. Oftentimes the doctor wouldn't even see you. They'd just call in antibiotics to the pharmacy in those days. So I do remember a few, we were pretty healthy kids, so we didn't have that many trips to the hospital or anything like that. But I do remember, having to go in the hospital when I fell and hit my head. I had a concussion overnight. And there was access to care for the most part. What I find is that the access to care does get a little harder as you become an adult with larger problems. And those long-term, less urgent problems can sometimes take a long time to get on the list to get treated. So I hear those stories from my parents and my siblings all the time. I went to medical school in Trinity College in Dublin, which is actually a different healthcare system. It's the Irish healthcare system, which is still mostly socialized, but there is a larger private insurance wing to it. So it creates a two-tier system. Those who have enough money will have a health insurance. And then when they do get sick and they have to be in the hospital, they'll get more likely to get a private room in a private floor versus, the public floor that might have 6 beds in one room. And so that's where I did my training. I went from high school right into medical school in a 6-year program in Dublin. And so we saw the gamut. I mean, a lot of it was pretty similar to what you'd see here, but a lot of volume and a lot of people waiting for things. ERs were always chock-a-block full. And when I did work for a few years after med school in Ireland before I moved here. And the big thing I always remember is that I had about 3-minute visits. I would see 40 patients in a day. But I would have one line charting. I mean, it was short and sweet. We had little sheets of paper and we'd write down 3 lines, the pertinent stuff, and that was it. But if you got somebody who came in the door and they had a particularly bad story, I would be way behind with my patients. So that was incredibly stressful as well. And the other thing was that if we had somebody who we thought we needed to send to the ER, you really wanted to make sure that it wasn't something treatable as an outpatient, because they would be going and they might spend 12 to 18 hours waiting to be seen. Mm. So chest pain, for example, if it was an anxiety, almost like an anxiety chest pain, you'd be like, okay, is it really, what are the risk factors here? Do we really need to send them? So I didn't like that either. And at that time I was also playing in a band. And so I was doing mostly moonlighting to pay the rent. But after a few years, I was like, this kind of stinks too. So when I met my husband, I'd met him years ago prior to that playing Irish music. But when we decided to move here, I was kind of, looking forward to a fresh start to see if something, how I would, to try a different healthcare system where it wasn't so overloaded and access to care felt like it was a little bit easier to achieve. So that's what led me here in the early 2000s after I got married.
It's amazing. And, you come from such a wealth of knowledge, your experience in a different healthcare system as a kid, but also, in private practice prior to moving here. So I want to ask, especially for those people who might be coming over to the US to start residency, even though they're already a fully practicing physician in another country, what was that transition like to the Chicago area when you started in your residency program here?
that was one of the toughest times of my life, even though I was a newlywed. And I think that it actually took me about 2.5 years to fully transition into medicine here. Some of it was those darn USMLE steps that I had. I was going back to like early med school, biochem, etc., and that was really tough. So it took me a long time. I took a Kaplan course. I ended up having my first baby in that time, and then trying to get the externships, getting the experience, the work, the letters of recommendation, etc. And I feel like my first 3 months of residency were absolutely insane because I was learning a totally new system and totally new system of charting and everything. But I also felt that those 2.5 years were time I never stopped working again because of that. I always worked part-time through having babies, etc., because I felt like that time out of medicine was very difficult to transition back into. But on day one of residency, I was lucky enough to have a great class who were still in touch, and we're, best friends now. So I feel like once I got my groove, I was on the same footing then as everybody else. And to that point, I think that I also had a little bit of head start because I'd had so much experience. And so a lot of the patient interaction, etc., wasn't hard for me. A lot of the differential, etc., it was more the system learning that was difficult. I'll never forget, I tell my med students this all the time. My first day of residency, my nurse handed me a blue sheet with like all the CPT codes and the, level 1, level 5. I was like, what's this? She goes, it's your billing sheet. I was like, okay, what do I do with it? So my nurse, Therese, shout out to Therese from residency. She took me under her wing and she taught me all that stuff. I just always thought it was so superfluous to what I was supposed to be doing. And, that was just, we never had any of that in my old, in Ireland at all. It's just get the patient visit done, you take care of them, you get the medicine prescribed, and then you move on.
This is exactly what I was going to ask you next, was when you moved and you went through residency, were there other things that you were like, I was really hoping that this would be how the US healthcare system would be like? And did you find anything that you were glad to see in the US healthcare system that you didn't see in Ireland?
So I feel like, the story changed between beginning of residency and by the time I started my DPC practice, because as I teach in the course that we're going to talk about later for the med students, Obamacare, ACA, Affordable Care Act happened right in the middle of that time. And that changed it for a lot of us working docs. At the beginning of residency, I would say we didn't see as many patients. I loved the ability to be able to really get into this story. I did have a lot more freedom to be able to get patients to the specialist, or, the care that they deserved, or have them come back for follow-ups, or even just getting into the therapist at our residency program. But, in the first 3 years, you start to see a lot more patients. So by the end of it, and then private practice, you start just knocking them out, hand on the door handle, trying to get to the next patient. And the patient, has got 3 more things to ask for you. And then it became more and more tricky to get what they needed. The prescriptions at the pharmacy were denied, and you had to write a prior authorization for, an SSRI that costs $150 a month, or you couldn't get them in to see a specialist for 3 months, but so we had to make calls. And that was not the case at the beginning of my American career here, but it was by the time I started DPC. It was very much a huge time waster for us. Sure. When you just wanted to take, to do the clinical medicine part. I do like the fact that I don't have to really think about sending people to the ER for the most part. Now I do for a cash reason, for a pricing reason. I try really hard not to send them to the ER, but I know they can get the care that they need when they need it at the ER too. So that part is really nice. And I also have made it a huge goal since I started my DPC to have connections with a lot of independent specialists in the area. So I'm able to get most patients the care they need in specialties because I've developed those connections. And most of the time cash pricing. So for example, I have a new patient who pretty much ripped a hole in his shoulder, and he needs surgery. He's a hardworking gentleman, and his employer called me. His employer is my patient, and we did an MRI, and his shoulder is just, he had an accident at work, and it's just ripped to pieces. So the surgeon that I know in the area, I texted him and I sent him the MRI report on Friday, and he sent me back a whole list of all the pricing, and he's going to see him for free for the first visit, and then we're going to work on getting him the surgery that he needs. That's because I built that, I feel like it was easier for me to get that because I built that relationship a couple of years ago with this surgeon, and he's very grateful to be able to help our patients when I need it. He's done, I think, 2 other surgeries for patients of mine before.
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. I think this is so cool though, because you have such, like you said, when you started residency, you had a very different training background, but in general, you have a very different bird's eye view of how people can be treated as patients in different systems. And, what the ideal system that you could build would be for your patients. And so I want to ask there, how did you go from your private practice to learning and then opening your DPC?
So it's funny because I was, I think probably like many of my generation of DPC physicians that, the ACA started to change things for us, and I didn't even quite know it those first few years. And I was lucky enough. I wasn't overburdened with all the stuff that we talk about, and, I wasn't in a corporate practice. I was with one other doctor who was self-employed for years and years. And I feel like that also, I learned a lot from him. I watched him running his practice. And it was more than the insurance side of it that kind of burned me out. And plus I realized that I did want to be my own boss, and, it was his practice. So he didn't really want to share it, full-time, long-term with me. So I feel like when I transitioned, I was starting to burn out. And I was spending way too much time charting at home on the days. And I was part-time, but I had 4 little kids, and I tried to be present for them on the days I was off, but I was charting during their nap times, and, just getting frustrated. And my husband was getting frustrated too, because I was spending too much time with the computer. So I started looking around, and I have a friend in biotech. So I reached out to her. I looked at, pharmaceuticals, and I talked to a few other doctors. I considered concierge medicine, and I just didn't appeal to me. So considered occupational health, all the different stuff that I think we all go through. I knew I didn't want to go to another practice or a corporate job. I knew that would be worse. So then one of my teachers in residency, she was 3 years ahead of me, and then came back in my 3rd year to be a preceptor. Her name is Dr. Sheetal Bhargava, had started her own DPC practice about 1.5 years prior to mine. And we had one of my residency classmates had worked with her in her previous private practice. So we had this connection. I'd hear how she was doing from my friend Therese, another Therese, Dr. Therese. And so eventually I called Sheetal and I said, can I meet you for breakfast? Because things were starting to unravel in my other job. My MA had just left, and it just, things unravel at that point. And I still remember it, the light bulb moment, an hour of breakfast, and I was sold. And I have a picture of that day, and I tell her that's the day that my life changed. And I went home and I told my husband, I want to start a DPC practice. And he said, a what? I hadn't even mentioned it to him before. So that was January 2017. And that then the ideas started, I started really researching. So I think a lot when I talk to other docs who want to start a DPC practice, and everybody does it differently, but I immersed myself in DPC, everything DPC. When I was cleaning out a closet, I was listening to a lecture by Julie Gunther at one of the, nuts and bolts, or if I was in the car, I was listening to another podcast. There weren't that many podcasts actually at that point. It was more YouTube videos of lectures. And I listened and I read and I got all the, the books that I could. And I mean, there's a wealth more especially, your podcast especially, but even more books written since 4 years ago. So, and I joined one of the Facebook groups, and I contacted a few people who I thought had a similar way of practice that I wanted to achieve. One in particular is Dr. Kissy Blackwell. I called her. She transitioned her practice 3 months before mine. She grew way faster than I did. So I always felt like, okay, I mean, if she can do it, I can do it. One was Dr. Rebecca Bernard in Florida. She was wonderful. Every single one of these people that I called or texted offered me their time on a phone call, at least one phone call, if not more. Dr. Sheetal, oh my gosh, how many times did I call her? She was so kind and sweet. And so that was one of those things I have continued to pay it forward. And I think people who I have mentored continue to pay it forward too. And I think that's one of the lovely things about our community. So I immersed myself. I told my current office manager, who was my front desk lady in the old practice. I told her in February. She left in March. I gave in my notice in May. I left in June, end of June. I did my first town hall meeting in June. I was very lucky I didn't have a non-compete. Mm-hmm. And so I sent out a letter to the patients as soon as I gave in. The first person I called when I handed in my notice was another doc I heard was retiring around the corner. So I called her and I said, can I come see your stuff? I'd like to buy some of it.
Yeah.
Sent the letter, did 2 town hall meetings, one in June and one in August. 50 people arrived for the first one. They all signed up. And some of them brought their friends and family, and they signed up too. 9 came for the August one. So not very many, but they all signed up too. And most of them actually are still patients. So I can't emphasize enough the town hall meeting. If you have the opportunity to take patients with you, let them understand the model by talking to them about it. And I had not done any public speaking for 15 years. And I was so nervous and so sweaty. And it's still on my website, actually, that very first meeting that I did, because I feel like your patients love you and they're sad that you're leaving. And the ones who come to those meetings really, really care about you because they want to know what's happening. You accumulate more patients along the way later that are there more for the financial benefit, or maybe they've been burned by another, corporate practice or something like that. It's less about you. But those patients at the start, I'm still getting patients who emailing me from my old practice saying, we miss you. We want to come be your patient. How does it work now? But it is also interesting because, I think I had a little bit higher the average for people transitioning over from your private practice to a DPC practice. I want to say the 10% maybe. I think I ended up with about 20%, but not all have stayed. We have churn like everybody else, and some people move on, but I'm still getting more coming on. And some of those people joined that September, and they're still my patients 4 years later because we had that connection already. And now we have a deeper relationship because we have more time together. So that, I think that's the big thing I always tell people considering it. Learn about it. Read about it. I mean, I went and I watched town hall meetings that people had done for their practices. I contacted a few people who'd done that. Every step of the way, I tried to find somebody that had done something that I thought would be helpful and that the general DPC community had recommended. And that all that hard work paid off, because then when it came to marketing or selling myself, I really knew all the answers to all the questions very well, and I didn't come across as I was, had no idea what I was talking about. And I think my first conference I went to was in November 2017, 3 months after I had opened, and I already had 150 patients. I opened with 98 patients. I had, I think, 75 at about 10 p.m. the night before I opened, and I went to bed. I had this whole, waive the enrollment fee if you sign up before September 1, sent everybody, had an email list from my old practice, sent everybody the email. I woke up and I think another 25 people had signed up, something to that effect, because they didn't want to miss out on the discount. So I opened with 98 and it grew fast. I had another event in that December with open enrollment. No enrollment fee at my practice, and I got another bunch. So by 3 months in, I had 200. My office manager started with me at about 5 hours a week, but it grew very fast. And so it was drinking from the fire hose for about a year and a half. And, but I always, I kept in touch with Dr. Blackwell. And her fire hose was much bigger than mine, so I always felt like I was, because she went to 700 in 6 months or something. And so we capped out at about 320, and that would have been just pre-pandemic, like fall 2019. At that point, I'd added a part-time nurse, I think about 9 months prior, and we had started to stabilize. And I pushed it up a little bit. My thought had been around 300 for a while until my kids are. I started my DPC a week after my son started full day school. So I was in your position for years, with a kid at home. You never really get anything done on those days you're off because you want to play with them. You've got that guilt that you're going to get work done, but you want to sit on the floor and play with them. So he started full day school, and a week later I started, definitely full time. I feel like it was full time in school hours for about 2 years, maybe 1.5 to 2. But now it's not. It just was so much fun too, that I really did want to work on it. I wanted to build it. I wanted to streamline it. So by 2019, I feel like we had, gone to that level, and my my office manager and my nurse are part-time and like being part-time. So at that point, we started to bulge a little bit. Either I was going to have to work more hours than I wanted to, or they were going to have to take on more, and they didn't really want to at that point. And the thought of adding a third employee was not, enjoy, like it's good to have the two, but I didn't want to have a third person to manage. So I decided to back off a little bit. And then I did get the opportunity to build a course for the med school. I think we're going to talk about that. So that helped me. I have actually trended downwards a little bit since the beginning of the pandemic. So we're now at around 270. And with the teaching as well, because I do spend some hours every week on that it is very doable, and it's not a full-time job anymore, even with both jobs. And I think, it's less, at this point, it's definitely less hours than what I was doing before. Evenings and weekends are free. Wednesdays and Fridays, for the most part, apart from my teaching, are free, and we're still busy. But it's not nowhere. It has worked out very nicely, but it was a hard slog for the first 2 to 3 years.
When you talk about this idea of building and streamlining your practice, I want to first talk about team building, because you shared how it was Paula, correct? That was your front office person and is now your office manager. When she had left in March, when you had handed in your notice in May, how did you guys even collaborate together to have her there on opening day at Cara Direct Care?
I was lucky that Paula was there from the first day in my old practice. She had been working there. I think she worked there 5 years before I came, and she didn't have that many hours. And I was starting a new doctor, and so my boss offered her if she wanted to work with me on the day he was off. So then we, after several years, and of course with all the busyness of the regular private practice, it did get very stressful at times. But we worked well together, and Paula and I are lucky enough to be able to be upset with each other and leave it at work and move on. Neither of us holds on to that, and she's been very much in personality, very much like my husband. So there's a good connection there too. So Paula was and still is the number one advocate for direct primary care, for Cara Direct Care, and for the success of this practice. And I mean, Paula will go to the dollar store for something and she'll buy some organizational things for the office. I think we might need this. She tells people about it. She has read all the books. Like, she's really very much has been an advocate and really believes in the model. And that's hard to find. I think that a lot of us don't have that in our DPCs. I just got really lucky. And also I do, try to make sure that the job is good for her too. She probably, she has a lot of flexibility, and, they work from home a lot. If we don't have patients scheduled, answering calls from home and things like that. So then with the pandemic, and we had to really tighten our social circle and our work circle, Paula and I have become even closer. She's going to have surgery on Tuesday, so 2 days from now, and she's going to be out of the office for a few weeks. And I am like crossing myself, praying that we don't all fall apart. Maggie, the nurse, is wonderful too, and kind of knows a lot of it, but Paula knows where everything is. She knows how everything works, and I think we'll be fine. But this is she's always been like, just call me. All I'm going to be doing is sitting around with my leg up, that sort of thing. So that is a hard person to find. But if you have one of those and you can take them with you, or persuade them to come work for you, treat them well, share in your success with them. So Cara cares as much Paula's as it is mine, and she's the biggest advocate. So, and Maggie came in actually as a patient, and we got to know each other and her family, etc. And then I was looking for someone. I wanted an RN so she could dispense, draw labs, do all the stuff, but also triage. She came in, I think, about a year after she became a patient, and it works well for her life as well. And it's really nice, because last summer when I went to Ireland for 3 weeks, Maggie came in a couple of times and saw patients for me and FaceTimed me and, did strep tests, or we kind of triaged the patient for me over the phone, and we were able to manage not to lean on our covering docs, because the stuff that came in through the door was manageable with her in the office and me on FaceTime. So that has been wonderful too, because then I have a little bit more ability to go away. And our covering docs didn't get one call in over 3 weeks last year because of the planning that we did. And you talk about the streamlining. I think the first day we opened, it was unbelievably disorganized, but we went paperless from the start. But day 1 and day 2, we hadn't got that figured out yet. So I had to scan in, the contracts and everything. I was like, this is not happening. So that was because that was a new skill for Paula and I to learn too. And we're not particularly fast at learning all the new softwares and stuff, but we try really hard and we make it work. But I feel like we're still learning a lot of this stuff. And but between us, we've tried to figure out what works, and we've got a pretty good system going now.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. That's awesome. And highlighting what you mentioned before, in that, patients really follow you, and they understand generally who you are, and they understand a lot of the times why you're choosing to do a model like direct primary care. I feel that patients are very understanding and forgiving sometimes when we're building our workflows out or changing our workflows and things like that. So I'm glad that that's, that your experience opening was drinking from the fire hose, but you've made it work. So I want to ask there, in terms of when it comes to the business side of your clinic and the workflows of your clinic, what have you found that was a really good, business policy to have, or a workflow to have, that you've implemented or changed over time?
So, one of the things about the electronic forms, and I think we're still in the midst of this, because to us, it's kind of an overwhelming task, because we're both, a generation ahead of you. But I said we started with paper. And then quickly we got it on, online in Dropbox, and we used a PDF editor app on an iPad to open up a contract, because I usually have the patient, we go through it on that first visit. We have a list of, criteria about DPC that they need to understand, and that they initial before, as we sign it. I feel like when people sign up online with their enrollment form and whatever, they just click the link. They don't always read the contract. So it's just that expectations. But on the PDF editor app, it was $10 or something. So it was great. Very, very cheap, but clunky. Because Paula would have to go through, when you see a new patient, she would be putting in all the initials, and then just kind of like we'd have to scroll through and get them to sign twice, and that it's just clunky. But it worked for a long time. So now we're working on getting that really like an electronic form kind of. We have I don't know that we use brands here, but we've got one where we send a link to the patient, and they do it themselves, and they can do it from their phone, or they can do it from the website. From the link on their email. But the issue with that is that it takes a long time for each one, just to get each one right on that too. So it's almost like we're rebuilding all the forms. But that's okay. We're taking it one at a time. We've got a few of the very common ones we use that are done. And I'm, trying to build that into my admin time, as to kind of work on that. Paula and I too, we're both, we work on it together sometimes. We've had some mentorship from, shout out to Madison at Dr. Tammy Waters' office, who did a Zoom with us one day. They have got it all figured out. And, that's the kind of thing. I reached out to Dr. Tammy and said, I know you use this particular software. She said, oh, Madison will teach you. So that has been really helpful. Just, camaraderie between office managers, and Paula really enjoyed that too. So that was a big thing. We are still on somewhat of a streamlined, or like the cheaper version of a lot of stuff. It's not that we have to be frugal anymore, but Google Voice, we have a Google Voice office line, and I know a lot of people move to something that is a subscription, but this one has worked for us for the most part. We have a Doximity fax that's free. That's a little clunky. We're still trying to figure out which one we're going to switch to, but we haven't done it yet, because that does take more staff time. And then we were using some paper forms for mental health and things like that, screening questionnaires. We're trying to get those onto our online as well, because we use them so much. Haven't got there yet. So the patient Paula has a bunch of like paper forms as well. And she knows when I come out of the room and I'm like, can I have this form? She has a whole concertina folder that works for her. We have a few other things that are still on paper, like our prescription ordering. This was one of our best things, I think. There's a couple of things. I know Paula invented a sign-out sheet for prescriptions that were picked up with initials only, not with patient identifying features. So it's like patient's medical record number, prescription number, date, and initial to when they picked it up. Because we have had a few patients who forgot they picked up their prescriptions, and they come in again. That only a couple, but it does happen. So for us to know, okay, they did get picked up, and we have that. And then with our prescriptions, we streamlined it during the pandemic lockdown. We had a little bit more time. So we always wait for that $100 of ordering wholesale meds to get the free shipping. But that meant our prescription ordering was all over the place. So we increased our percentage a little bit on the prescriptions to cover, then we order on Thursdays no matter what. Even if we don't have, generally these days we do have $100, but we do order from two different wholesalers. So sometimes we've got some in one cart and some in the other. So we order Thursday afternoons. People know that they they won't get them till they come in on Mondays, mostly inventoried on Monday and dispensed on Tuesday morning when Maggie comes in. She's not here on Monday. So by 10 a.m. on Monday, most time people can get their prescriptions, or they're shipped to the patient at that point. That has helped a ton, having a routine. And then the patients start to get used to it too. And every so often, somebody says, oh my goodness, I only have 2 pills left or whatever. We say, okay, we can get it overnight, and you can pick it up tomorrow, use just an extra $10 charge, and they're fine with that. Here and there, most people are used to it now. We have a whole system, and people like that structure too. I think that helps a ton with any, even a starting practice, because all that back and forth and never knowing when the meds are coming in. And if you're a part-timer, your office is closed, so they get bumped to the accountants across the hall. And then people, is my med ready yet for pickup? And you're in the middle of a full clinic and you haven't got somebody to help you with the meds, dispensing them. So having a routine on that, I think because that's a special thing that we do as DPC docs, it can get overwhelming. And I think that has helped us all a ton. I'll tell you that this week when Paula's not here and Maggie and myself are running the meds, but in general, the girls like it too. Do you dispense meds?
So I do. Because currently I'm still telemedicine and home visit on the way to a patient's house, or I'll be in the area. I'll just drop them off at a patient's house. So that's generally what I've been doing. But it's so wonderful because my patients have had, my insurance won't cover my lisinopril, and I can't make it to the pharmacy on the day that I need it, and I'm going to run out before then. And so that's been the use case where I've been able to bring medicine to them, and they have an extra supply so they can have coverage in case that happens again. Or it's Thanksgiving and there's no pharmacy open locally. So fancy that. I have some Macrobid and Keflex in my supply. It's
Right.
really, it's priceless when it comes to being able to give our patients access to care. So I love that you guys have the system. And I think that's such a gem in terms of having a routine, because we thrive on routines and our patients thrive on routines.
Yeah, absolutely. And I think my favorite story about the what you're discussing, so I had this patient who was homebound Alzheimer's, full-time caregiver, daughter lived in the area, and she would get UTIs. She actually passed away last year, but she would get UTIs. And I think I was finishing up work one day on a Thursday afternoon, 5:40, and I saw when the daughter called, I would always answer because I knew, she would get sick quickly. So I answered the phone. Everybody else had gone home, and she was having increased confusion. They just wanted to make sure she didn't have a UTI. So, and this lady lives right behind me. And I was able to, at 6:05 p.m. on my way home, I dropped off a specimen jar and an antibiotic. And so within 30 minutes, without the caregiver having to do anything, I was able to help that patient. It was just kind of, it's nice to be able to serve people like that. Yeah. And not watch them go through the system and be frustrated and waiting. And yeah, there's a certain element of those that lady's daughters would have done what needed to be done to get that. But I was able to. I was on my way home anyway. I said, I'll just drop it off. No problem. Yeah. So yeah, it's really now I don't always have the right prescription in my office, and I have learned that there's certain ones I use more than others, and I'm starting to not order some of them and just send them to the pharmacy. For example, I've never had suspensions for kids like amoxicillin and stuff like that. They're just a little trickier, and they're just cheap. So there's certain things that you have to be very careful not to order all the things you think you might need, because a lot of them will expire, and then you have to pay for those. And I think we all learn that along the way, and checking GoodRx and making sure that you're not dispensing something and using staff time to dispense something that's just as cheap on GoodRx. So then we're not getting compensated for our time. So there's that balance there. But then when it comes to patients who I just ordered a year's supply of something for a patient who I know comes in every 3 months anyway, that just kind of like that saves a lot of time for them calling, picking up the prescription, etc. So it's nice to be able to do those things.
Yeah. When you mentioned the year-long supply, I have a patient who's on a PPI, and their insurance, only covers 30 days at a time. And the price for the PPI with the insurance was like $25 to $30. And I was like, what if I could get you 2.7 years for the cost of less than a month of your PPI for the exact same PPI?
Oh my goodness.
Yep.
Yeah.
And so
yes, that's exactly what I just ordered, was 1 year's worth of it. Oh, and it's an over-the-counter PPI, but it's much cheaper through us. So that's just that's nice. But I do feel like we're trending towards the dispensing as more for the long-term chronic stable stable medication patients. And then when we're adjusting meds, or so a lot of those, I don't keep all the antibiotics in the office anymore because they expire. Patients have not been as sick the last 2 years too, because of COVID is the only thing we saw for so long. So a lot of my antibiotics expired. And so I'm trying to keep just a few of those. But it is very nice for them to be able to, walk out the door with their prescription for sure.
Absolutely. And when we're talking about pricing, I want to ask about overhead, because that's a big thing that people who are, they might have loans that they're paying off, or they might have a family where they're the primary breadwinner. How did you develop your business model to make sure that your overhead was working for you and allowing you to have the practice you wanted to have?
So when I started DPC, I started DPC to stay in medicine, not because, not to like make more money. I think that was the big thing for me. I also, my husband is not in medicine. He is a full-time in finance. He's a spreadsheet guy. And so that has always been a nice balance for us, because one person in medicine is, they're always a little bit more, work a little bit more hours and things like that. So ways I kept my overhead down at the beginning, I bought retired physicians' equipment, furniture, and most of it I still use. And then I also, the office I'm sitting in right now, it's like a 3-room, 1,200 square feet office, and it's in it's in a building with 5 other offices, 1 accountant, 3 dentists, and a hairdresser's. She's right across the hall. She takes care of all the little old ladies. So it's perm day on Fridays. It permeates underneath our door. So this doctor, I knew her names, and it's really close to my everything that in my life. So my old residency is 2 blocks away. My house is right across the street from my old residency. Ironically, I didn't live there in residency. My kids' high school is in between those 2 things, and my kids' grade school is about a half a mile around the corner. So very, very convenient. And I've discovered as a mother of 4 that wasting time on commute is never a good thing. It's like literally 3 minutes from my house. So I really wanted to have something close. And I called this lady. She was still working at the time, probably about April or May 2017, and said, "Can I sublet a room from you?" And so I did for a year. And I paid her, rent. And then she said, "I want to retire. Do you want to buy the office?" So I bought the office from her 10 months in. And so my overhead went from probably 20% to, maybe 15, 20%, because I was on that low rent and everything was very, very frugal. But then I had to kit out the office. I had a mortgage, I had taxes and all that sort of stuff. And I did a renovation, construction loan, renovated the office. So now I own this office, but my overhead is higher. Mm-hmm. And so one of the things I did do pre-pandemic was started to think of our ad subletters. And I had 2 mental health therapists subletting for a while. The pandemic kind of decreased that. They're not here right now. But my overhead is probably higher percentage-wise than I would like. And why is that? Obviously I would like to make more money and not have as much overhead. But I think it's because of where I am in the number of patients on my panel and where I am in my family life. Buying the office was an investment. Mm-hmm. And one of the goals would be either to add more patients, add another practicing physician to the DPC, or sublet to other, specialists or other doctors or other people like therapists, etc., in order to decrease my overhead. I'd say probably 30%, maybe 35%, which I don't really want to add more patients right now because I'm enjoying the teaching, etc., but it is definitely a goal to maybe get somebody else in here to use this on the days that I'm not using it. It just has the pandemic and everything has just kind of changed people were not taking risk and starting new things, so there wasn't really anybody looking for a long time. So now that we're moving past that, hopefully a little bit, I'm hoping to get to use the space more. But I do use it myself. For a while, we had a music teacher on Sundays who was using the waiting room to teach our kids Irish music pre-pandemic. Since everything opened up, he has decided not to come back. So on Wednesday nights now, I'm teaching Irish music in the waiting room. So that's something.
I love that though. And, you're being creative, you're thinking out of the box when it comes to, other people using your space, but also it's just really important that you shared that for people who are planning, especially, in the next year or so to open, because they can start playing with the numbers. Like, if I have this, what would it look like for my overall budget? What would it look like for my overall overhead or investment that I have to have going into DPC? So I think, those are extremely helpful parts of your practice to hear about. Now, one of the things that you had mentioned that I want to go back to is when a patient joined your practice in the past, when when you accept people off your waiting list now, you said that there's a criteria for patients to join your practice. So I'm wondering if you can share a little bit about how onboarding works for your patients, how the discovery calls happen in terms of, when someone's interested in the practice, they're saying, yes, I would like to join. How do you see if the patient is going to be a good fit for you and vice versa?
So great question. And I think that also has changed a lot. And I think it's very natural for that to progress and change. When you're first starting, you are, you just love people calling and you want to give them the best help. Then once you get to a panel where you're happy with it and you have the ability to form a waiting list, you can choose to do it different ways, but the way that we find works best for us. And actually, we just got a new workflow for this recently. Within the last few weeks, we decided that. So what we do is patients will usually reach out through the website. They send a message, I'd like to talk about joining the wait list, or they send an email and they say, I'm a friend of X patients and she recommended, how does it go about, how do I join the practice? So generally usually Paula or Maggie will call them back, answer some questions, but then schedule them for a phone call with me. And it used to be we would fit the phone calls in between clinic patients, but then the phone calls would get a little bit dropped because they just, things would get a little crazy around here. I've got med students following me around too. So within the last few weeks, we decided to do the phone calls on Wednesdays just before I teach. So Wednesday lunchtime is now when, if we can, with a prospective patient, even if they call on Thursday the week before, we say, oh, Dr. Ryan does calls for new patients on Wednesdays. Because then that's in my schedule. So that's working out very well, actually, because then I think about it, and I feel like on the first impressions, it's not good to miss a call with a prospective patient because you're seeing clinic patients and have to call them back a few hours later and say, sorry, I not forgot, but we ran out of time or whatever. So I think that was bugging me a little bit because I felt like they would, that wasn't good from my perspective either. So then when we do call them, I usually ask where they heard of the practice and what do they know about DPC. And I get a good handle on where they're coming from and why they want to be part of the practice. And I get quite a mix of patients. I get a lot of access to care patients. So they may have, this is a relatively middle class neighborhood, and a lot of people are more, I'm not being heard. I need an advocate because I've got XYZ chronic conditions and I'm so frustrated with not having enough time to be able to, have somebody to help me. So there's a lot of those. And then I get, the employers calling or the uninsured looking for, something, or the large families and I get I've been having a lot of about 40-year-old wives calling this is very common in the Chicago area. They all live in the city and then they have their babies at Northwestern in a very well-known maternity, right? So they go to their OB for 10, 15 years. They move out to the suburbs when baby number 2 is on the way. And then, they're busy having babies, raising them. And then when they hit 40, they're like, okay, time for me. I don't have a doctor, right? So I've had a bunch of people join in that stage of life who are very health conscious. And then they get their hardworking husbands on board. And they're a very nice group of people to take care of because they're very appreciative. So that's been kind of a nice little demographic that has been growing recently because the word is spreading. And it's usually patients who tell other people, and then they become patients who tell other people. So those phone calls are very, very important because I have developed the ability to understand what they need and whether they need it fast or whether they really understand what we're doing at all and what they're looking for. And for the most part, then we put them on the wait list and we try to assess, when they need to join. And I do think that the best DPC patients often are those who are willing to sit on the wait list. Because if they're willing to sit in the wait list and 2 months later, 3 months later, you're able to squeeze them in, they're more likely looking for the long-term relationship. So that's been nice. most new DPCs can't really afford to play that card, but and then there's others who you can tell they just really need somebody, and sometimes I will bump somebody up the wait list.
Sure.
Due to need. And we have a new patient coming in soon who literally needed a patient advocate with XYZ, friend of a current patient. And I could hear the anguish in her voice. I'm like, she needs me. So it just depends. And, we always get DPC, the people always say, cherry picking and all that stuff. I think cherry picking is boring. Like, I like the difficult chronic condition stuff. I like the challenge. I like to see patients who have, 20 medications on board and try to, create the best quality of life that I, can achieve for them. So we have more time to do that. So we do. I think I'd be, cherry picking those healthy patients. I think that's not that much fun as a doctor.
Yeah, no, I agreed. And I just so many things come up in my mind as you're speaking there. I in my old practice, I remember when a patient called, our new patient panel was closed, but we still had people on the wait list. And there was a person who had a recent cancer diagnosis, moved to the area, couldn't get care. And, if a patient is in that type of situation and then joins your practice or another DPC, it's not only the access to care that they get, but then it's like, oh, here's a doctor who also has the time to then go through all of the history to figure out what's the best way that, the doctor can advocate for that person as a patient. So I think that's so amazing that, like for that, the patients who do go up on your wait list because of need, it's like, they don't even know what, this magical Pandora's box that they've opened is afterwards, because they've probably never experienced direct primary care like you provide them. So I think that's wonderful. And then the other thing I think about is that, with the chronic issues and the cherry picking, it's so interesting. I spoke with a physician who had tried to do a business model where it was just a fee per visit. It wasn't a membership model. It was a, pay as you go. And they were in such disbelief that direct primary care could work for anybody who has more than 2 chronic medical issues. And, just being a DPC doctor, speaking with a DPC doctor, it's like, that just it's completely, it blows my mind. And I'm sure it blows your mind, that the idea that when people have a relationship-based doctor, a relationship-based physician-patient relationship, it's very different. And it is absolutely made for, in a lot of cases, those people who have multiple chronic issues, because for my patients right now, I'm seeing a lot of them are tied to lifestyle. I think that that's a big thing that, I didn't have the time to address before. So I think of those 2 things after what you shared.
Yeah, absolutely. And I think absolutely we have so much more time to get into preventive health. And I think in order to even approach preventive health, oftentimes you need to build trust first. And I teach that to the med students too, because we talk a lot about, as you know, I do a lot of metabolic health and, not so much weight loss medicine, but we do try to broach weight loss and getting healthy, etc. But one of the big things I tell the students who ask, how do we talk about this with patients? It's really hard. And I say, don't talk about it in the first visit. And the second thing is, don't get your nurse to weigh them as soon as they walk in the door. So, we take it slowly and leave shame out of it and be compassionate. So much easier in a DPC practice because we've got plenty of time. And I feel like the nice thing about the chronic disease patients, and then even the sick ones and the ones who, because we all have patients who pass away, right, is that it's nice and it's not, because every time a patient dies in my DPC, it is much harder to process. It's because the relationship has become much deeper, even those who were patients of mine in the old practice. So one of the ways that I'm able to deal with it is that I offer to play music at their funerals. And so I get to say my goodbye through music. And I've done that now, I don't know how many patients, 6 maybe. I played at a funeral yesterday. It wasn't a patient, but it was his grandkids are my patients, and mom was a friend before becoming a patient here. So I played at granddad's funeral. I've known them for many years, etc. To be able to give that to the patients who, that personal side of me. Sometimes some docs might feel like that's crossing a boundary for them. It's music, so I'm able to give a gift of being, and that's a gift to me too, because I get to say goodbye through that, and having it, Not everybody maybe wants to have that, but it is something I do offer if I'm able to. And if I can take the day off to go to the funerals. I mean, I never did that either, right?
Yeah.
So it has been, in that way, it's been very, very fulfilling.
That's awesome. When you talk about fulfilling, you've mentioned how you do mentor medical students and as well as other DPC physicians, but I want to touch on that too, because, you are an example of how you can craft your DPC to allow you to live the life you want to live professionally as well as personally. And so you are on faculty and a preceptor at the Chicago College of Osteopathic Medicine, and you have developed your own course that you teach to medical students. So can you please tell us a little bit more about how that even came to be and what is it that you are able to share with medical students regularly?
Yeah, it all kind of fell into my lap in a way that I didn't expect. I think going into DPC, I think I had this expectation that I would start at practice, build it at some point when my kids are older to full time, and that's what I would do, just like I was doing for the last 8 years. But DPC opens so many new doors, and it opens so many new sides of each of us that you didn't know were there. I think that was the big thing that I realized, that my DPC has taught me a lot more than just direct primary care or medicine. Mm-hmm. It's taught me that I can do a lot of other things too. So at some point, I think in 2018, I started taking students in my office from Midwestern University, Chicago College of Osteopathic Medicine. And full disclosure, I am not an osteopathic physician. I wish I was. We didn't have that option in medical school in Ireland. Osteopaths in Ireland are more like chiropractors. They're not medically trained, but I was always interested in it. So I was delighted to be able to take students from there. And then that was 2018, and they would come through, for a regular month at a time. They would rotate with me, etc. So then they asked me to start teaching a DPC lecture within the family med rotation. So I've been doing that since about early 2019. Once every 2 months, I go in and I have a DPC lecture. I teach them, answer all the questions. And I've done a few more lectures on different clinical topics as well during that day lecturing. So I have a few, so I've built that up. And then what happened was when the lockdown happened, telemedicine came to the forefront of the medical schools committees. They were like, we need to teach telemedicine. We have never really thought about that before. And my name came up as the only faculty member who didn't have to spend hours and hours trying to figure out how to run their practice in March 2020. It was already happening in my practice. So I was asked to develop a telemedicine curriculum initially, but I put together a proposal and I decided I would throw in a lot of the other stuff I thought that my students should know. So it ended up that this curriculum that it happened to be on the dean's desk, and he called me in May 2020 and he said, we don't just want you to teach a few students a month on this. I really like all the things you have to teach about, and can you take the whole third year class in July 2020? Because we have nowhere to put them, because the hospitals are not open yet, and they are supposed to be going out in their rotations, and we can't do anything. So could you develop this curriculum to teach the whole class, 200 students, for the whole month? So I happened not to be going to Ireland that year because of the pandemic, and I was like, okay, I never challenge. You challenge me, I will rise to the challenge. So that course was probably closer to Kissie's fire hose. Let's put it that way. 12 hours a day I think I started preparing, because of the way that it all worked, about 3 to 4 weeks prior to starting teaching. Mm-hmm. And there was 4 1-week modules, and I was still building module 3 and 4 when I started teaching module 1. So it was busy, but it was fulfilling because it was all the stuff I wanted to teach. So our modules, the first one is all on telemedicine, history of telemedicine, how to set yourself up, get the lighting, all this stuff, how to take different cases. We do cases throughout the whole 4 weeks, and we switch them to just learning about clinical medicine. But how would you approach this if you're on a video with the patient? So one of the ones we did last week was shoulder pain, and I usually wear a tank top and have them show me how they would tell the patient to examine their shoulder, what they could and could not do on a telemedicine visit. And then the second one is like the meat of what we are all in DPC for, and it's called the healthcare system and beyond. Okay, American healthcare system and beyond. So we teach about the history of the healthcare system, Obamacare, and all insurance billing coding, mid-level differences since Obamacare, and DPC. And then the third one, we kind of take a step back from the heavy one, which I always call module 2. We're starting that next week with the students. I always call it the heavy one. And we go to metabolic health. So a lot of the stuff about intermittent fasting and the difference between a whole food plant-based diet and a low carb, high fat diet, and what suits each patient, how to deal with obesity, how to talk to the patient about, weight, and how to frame it in a way that they can hear, etc. And then the last one is coming full circle and talking about starting your own practice, business, pharmacy, running your own pharmacy, career goals on how to achieve them, what setting in medicine you can see yourself in, and how is it going to affect your career long term. So I make them think a little bit about themselves, and I make them write a business plan for their future practice. Even if they're going to be a hospitalist or an ICU doc or whatever, they still have to think of something. Overhead and budget and everything, I make them. So it's kind of fun. It's like a mix of different stuff that I did for this class of 200, and that per class, I mean, having to deal with me, I couldn't even see them because we were on WebEx, and it was so clunky because there's so many of them on. And there was times, the software, we had tech issues and whatever at the start, and I just had to be really self-deprecating and like make fun of myself with no laughter coming back. I couldn't get any feedback. So I have to say, it went pretty well. The feedback was pretty good. They were all still pretty disgruntled at the fact they weren't in the hospital. So it was probably good to have, this woman with a crazy Irish accent making fun of herself, at least to, on this course. And I taught 2 hours a day, 4 days a week for 4 weeks, and then tried to create as much as I could and read out stuff. And I get so many emails and stuff from these poor students, going through a lot of the stuff, and even their own insurance issues and all the stuff. We teach them about their own insurance. I make them look up their own insurance. I make them call local hospitals in module 2 to get the price of a HIDA scan. They have to get somebody on the phone and get a cost price. Like that, these kind of little things that they don't ever hear of in their rotations. So then that led to the school saying, was a good success, would you do it on an ongoing basis? So we've been doing it for smaller groups since January 2021, usually anywhere between 4 students and I think 16 to 20, which is an absolute breeze now. So I do it from September through June, and then I take the summer off, and it fits in nicely. Now we don't do 4 hours or 2 hours a day. We do 2 hours a week in person, and most of the rest of it is asynchronous. Some of the videos I did from July 2020, they have to follow. But we have great discussions, and I get to meet some really great, the students are just, it's so awesome for me to hear what they have to say, because I keep telling them, you guys, like, you're going to be taking care of me when I'm old. Mm-hmm. Like, it's important for you to understand where you're going, and this is not to depress you about your future. This is to empower you to change the way you think about it, and to have power when it comes to making these big decisions about where you're going to work and how you're going to advocate for yourself. And so, medical students are a very altruistic bunch and idealistic as well. And I was absolutely there in my 20s. And then you start to go through the experiences that you go through from residency and beyond, and you start to get a little hardened and a little frustrated and maybe a little not enough sleep and not enough time off and struggles at home, or, just you sacrifice so much. And I'm trying to give them, and sometimes making a choice that puts you first as the medical student or the resident, making sure that you're not taking that contract for the bonus, and looking at the work atmosphere in that job first, empowering yourself to look ahead. Because I think it's very natural. Medical education is so darn long, and we sacrifice so much that once you're there and you're starting to make money, you just want to get out and work. You want to feel like you're making a difference, but you really have to choose that so much more carefully now than even when we came out of residency. And I came out in 2008. The contracts are so much tighter, mm-hmm. and they will expect more of you, and you have less autonomy. in many jobs. So we do a lot of the teaching in this course. I throw a lot back at the students and make them really think about the future, where instead of thinking from rotation to rotation. So they usually leave the course and feel a little bit like that they have more knowledge, and I say this is just a start. You don't have to remember all this stuff, but maybe when you start to live it in the future years, you're going to come back to this, or you're going to come back to me and say, what was that thing you told me? Or what are or you're going to get a lawyer to read your contract that knows what they're talking about before you sign the contract. Or you're going to not stick in the job that you don't love for years and years. And that's one thing I wish I'd had mentors who had, I stayed in the job, my previous job, for too long. I should have left it about 3 to 4 years prior to when I did, but I didn't have anybody really to help me understand what was out there. So I'm hoping that, the teaching that they get, and this will lead them even just to start looking at other things and to start, understanding what's happening and to follow what's happening, So it has gone pretty well. I think that I've made a difference, and I have students then. The best part is when students come to my office to rotate after having gone through my virtual course, especially that one class of 200, because it was a really tough month for them. And then to see so many of them coming through my office, they're actually now just graduating this month. The guy who is in my office right now was in my class in July 2020. And so it's very gratifying. And some of them actually came twice to rotate. So I had 2 that came twice. And I have a few who are planning their DPCs after residency now, especially out of that class. They're a little further along, and so it's awesome.
What a gift, not just for the students, absolutely, but just for the listeners as well. I think that's so important to have those seeds planted at such an early time in your medical students' careers, because you're so right. All of us, we all should have, and we all deserve, that mentorship to help us honor who we are as people as well as who we are as professionals. So cannot give you kudos enough.
Well, and thank you. And it is nice too, because we have the time to talk to the med students, and the med students who come through my office, they have more time with me. I teach more than probably people who are seeing 25, 30 patients a day. And we flesh out really kind of tricky cases together. We look them up together and we will go through them together. So that part has been really nice. But I think one of the things that, just going back to the fact that I started at DPC thinking I was going to do clinical practice all the time. And then I discovered that I always knew I liked teaching, because I've taught Irish music since I was 16 years old. And my mother is a kindergarten teacher, and my sister is a physics teacher. And so when I started teaching this course, I was like, look at this, the teacher is coming out in me, and I really do enjoy it a lot. So one of my goals would be to bring what I teach to a wider audience, and I haven't figured out how to do that yet. Not just the students at the med school where I teach, that I just enjoy it. I've learned a lot, and I've educated myself a lot, and got good feedback. So, but I never would have said that 5 years ago, that I would be teaching a virtual class and wanting to expand it. I mean, that's the freedom, right? So the freedom to express ourselves. And if we like something, we go, we educate ourselves on it or follow that path, as well as doing our DPC. And I think a lot of us are those kind of people, like yourself, running your podcast. And it's been, that's part of the journey.
Absolutely. So awesome to hear. Now, I want to take a little bit of a digression, because you had also mentioned right before, we went into this deep dive into how you are mentoring medical students, but I want to ask about your husband, because you said he's not in medicine. And when you said, to him that day, like, hey, I'm going to open up a DPC, when people are thinking, oh, I totally want to do this, but they're the physician, and then their spouse, their partner, their family member is not in medicine. I would love to hear, for these people, especially, any words of wisdom that you might have from conversations you had with your husband, or things that you guys have had to think about since you opened.
Yeah, so I remember it took me a while to help him understand what DPC was. He knew I wasn't happy in my old job, and he wasn't happy. in my old job. So it was I'd gone part-time after residency in order to have babies and do all the stuff that from age 0 to 6 and be able to volunteer at school and grade school and things like that. And then the work part was getting so stressful. So I think my goal was to start a DPC practice, try and have it about 50% time, and then be more available on the evenings and weekends for my kids, because I was also working like every other Saturday morning and some stuff like that, and kids were getting soccer schedules on Saturdays. So the evenings and weekends are much freer. At the beginning, I remember about a year in, I was working my tail off, and he was like, I thought you were supposed to going to be working less. You're working more. I'm like, yeah, I know, but it's like fun work. I'm happy, aren't I? And I do remember him at one point saying, so how much money do you make? And I'm like, well, I'm not really sure. And, the first couple of years we probably would have, it would have been easier to predict the growth of my income and the practice had I not bought the office 1 year in, because that brought us backwards, right? And so that part, he's always about the spreadsheet and the finances and the budget, which is great because one of us needs to be, on top of that. And so those have been the questions. He's happy to see me happy. He's very proud of what I've achieved. He's pretty envious, I think, of the job satisfaction part, the helping people. He's met a bunch of my patients along the way who just, tell him great things, etc. So, and actually my oldest daughter started working in the office, I think, was it 3 summers ago, as a freshman summer, doing, Paula as her manager, and she'd be doing like scut work, as we would call it. And she went for a 360 on mom being cool, like to see the patients that actually came out of the office and I made them feel better, and they told her how, they were so happy to meet her. And she now is considering medicine, I think, because of that experience in my office. And I would never have thought that would happen. So my husband is very, very glad that I'm doing what I'm doing, because I think that, I have a much more routine now, and I'm home. I try not to do work at home at nighttime. We're so busy now with all the kids stuff that I don't know I would ever fit it in, really. And so, but for the first couple of years, I probably was bringing work home just because I was growing and trying to grow it, etc. And then we are at the point now where my income is more than I used to make at my old job, but it took a while. So he was very supportive. The first couple of years, we definitely tightened our belts, and, we took a personal loan to supplement the mortgage, down payment, etc., which I am still paying. Cara Direct Care is still paying off to us, but that was, that's the sign of a good spouse, right? They let you follow your dreams and they support you. And so I've tried very hard, and it is a juggle. I do try hard then to keep up my end of the promise, that it would be better for the family. And in general, I do think my kids have more time with me because I started this practice. Sometimes DPC gets in the way because we are on call and things like that, but it's not that often. And so I try to be very intentional about putting the computer away when needs be and spending time with them. Weekends are absolutely glorious. Like, compared to where we used to be, they're just so much better. I mean, I barely think about work on the weekends sometimes. It's here and there I get a call from a patient, but it's so different to the way it was before. And it couldn't have come at as I said, I started my DPC when my youngest started full day school. So he was going into first grade. He's now in 5th grade, and my oldest is a senior, and my second is a freshman, and my third is a 7th. So so it's busier now than it was when my kids were your age. Evenings especially. Trying to get people to get their homework done and not, and trying to get retail, like keeping on them for stuff, and then supporting their own. There's a lot of questions about life in teenage years and processing through social events and things like that. So it is, and then just the logistics. We're like pretty much, glorified chauffeurs. So just getting people from A to B and being, events managers and stuff. So I'm really, really grateful that we did it this way. I'm sure my husband may have a different take on it sometimes, but usually when I'm not paying attention to the family or the house or whatever it is, it's because I'm doing something because I want to do it. You know, it's enjoyable and it's exciting. It's not because I'm trying to catch up on the charts and the portal messages and the stuff and the, you know, the on the training that you have to do for coding and billing and things that are like, ugh. So I do try. I have my progression towards the DPC that I want to have eventually, and just the different things that I want to add in my career has been slower than it would be had I not got 4 children and a husband. But I think that's very normal. I have to put my life first and my work second. And this job does allow me to do that. And I choose the speed at which I embrace the work side. So you know, one thing I did do was I joined I'm now on the board of the DPCA Alliance, the advisory board. I think it was voted in January 2021. But to accept that nomination was difficult because I didn't want it to come in between, you know, with the family life. I was concerned it might take too much time. Mm-hmm. But my husband was very supportive. And at that time, you know, in the winter of 2021, we still were like, we couldn't go anywhere. And there was a lot of things. So that to me was a shining light in my month where I would get to have a board meeting with a bunch of like-minded people and some camaraderie, etc. So it has definitely been a balance. I've enjoyed it. But I have to be careful that I don't take on other things that could just tip me over the edge as regards too many work things and not enough family time. So that's always a balance for me because I do enjoy it too. But these times that, you know, we spend raising our kids, we'll never regret, and they'll be gone. My oldest is heading off to college soon. So a few more years, I'll be saying, oh, where is everybody?
Yeah. So true. And for those of us who are listening or who recall the days of having young children, this quote that I heard off of my Love Every mug that came with my kids' play kit was the days are long, but the years are short.
Somebody said that to me this week with teenagers. I'll just tell you that that stuff, there is a sweet spot, Muriel, like babies are really time intensive, and then you've got some of those grade school years are beautiful. That's like beautiful childhood parenting family stuff, and then the teenage stuff hits and it becomes more intensive again. But you know, at that point I think it's harder because as I said to somebody last week with teenage angst stuff going on, they're closer to where you are, and you're not always sure you're giving them the right advice because maybe you don't know. You know, maybe they might know a little better. So they're closer to adulthood. So you're always like, you know, okay, am I helping you form good adult opinions, or am I giving you my, you know, old adult opinions, you know? So, but it is very gratifying. I think teenage parenting is pretty awesome, actually. It's intensive, but it's awesome. My kids are turning out to be pretty good people. So I'm happy with that.
It's awesome. And when we talk about kids, I definitely have to include here the fact that you're teaching kids right now. You've been teaching kids since you were 16 music, but you're teaching in your own clinic, and you've been able to continue playing Irish music. And you've clearly highlighted how this job, how you choosing to do DPC has allowed you to have balance in your life. But in terms of the Irish music, I would love just to have you share about, you know, your history with Irish music and what that means to play in an Irish band.
Okay, so, well, I just wanted to say for anybody who's not watching but just listening, so Muriel pulled up a picture of an Irish pub, so that's her background for today. I've probably played music in that pub. I mean, those chairs look pretty familiar. So, you know, music came first and medicine came later. So I was, my parents are not particularly, they weren't into Irish music. But we fell into it. My older siblings got some instruments for Christmas one year, and there was Irish music lessons. So they started, I followed, and we had an Irish band with my family from the time I was 12 until I think my sister and her husband just disbanded it about 5 or 6 years ago. So I was with them for 10 years at playing gigs. I made more money playing Irish music than I ever did waitressing or anything else. It's good money too. So it's much nicer to play music than have to be, you know, schlepping dishes about and stuff like that. So it was always a job as well as fun, but it was more, it's very social. So we would go to pubs to play. We'd play in concerts, we'd play at weddings, funerals, There are competitions, there are dances, and there would be, just general weekend things where people would get together in pubs. Actually, there's one going on this weekend that we would love to be at. Our friends are organizing, and it's literally they mix different session musicians in different pubs all weekends. You get a schedule, and you're going to play with this person, and then you're going to play with this person. Super fun. You get to, you just sit down and you play, and it's really a very social thing. And so my husband grew up doing that here as well, with less of the social and more of just the music, in that he didn't have many people his age. So he went to Ireland a lot to play, and that's where we met. He was in a class with my brother when he was 14 at a summer school. I was 11 when I met him. And he kept coming back in his teenage years and early 20s. And then eventually we, reconnected in our mid 20s. But we always have had our social life revolves around music. So I would love to move to California, but there's not enough Irish music there. So I don't think I will. I landed in a good city for Irish music. Chicago was full of it. And I feel quite at home here. There's some great musicians. I'm very lucky that we are surrounded by music. And so that is definitely, music and medicine have always competed for my heart and for my time. And so it was really difficult in med school to play a lot of music, but I managed to do it on the summers and things like that. And then when I got this opportunity right out of internship in Ireland to go play with an Irish band full time, it was a good time, and it was like a fork in my training. And I said, yes, please. So I did for 3 years. I recorded. That's the one that's linked, I think, at the end of the bio. That was when in my 20s when I looked young. I recorded and played and toured in Europe and the States, Canada, and stuff like that. In between our tours, I would moonlight. So that actually was the greatest. I look back and I'm like, that set me up for DPC. Lots of different scenarios. I learned how to be my own boss at that point. I had my own schedule, and I took work when I was at home, and I went off for 4 weeks when I was playing with. And eventually I knew it wasn't going to be forever, because I had my training. And it didn't pay the rent. So it was more fun than financially rewarding. But I've never regretted those 3 years. It was all my, mentors and peers in Irish medicine just were like, you're doing what? But I feel like the training I got by just taking moonlighting jobs all over the place in different scenarios, that was very valuable too. So then my husband and I, when I moved over here, and I said I spent 2.5 years getting USMLEs and experience and stuff, he went into MBA school during those times. So we were really poor. And the only source of income we had was teaching music and playing gigs. And so we took anything we could get. On St. Patrick's Day around here, you play from 10 a.m. till 1 a.m. and you make more money in that time and that one day than you do in like 3 months for music. So we took every gig we could. And so we kept teaching. We didn't do as many gigs once I started residency and had my first daughter. And then I, shortly thereafter had more babies. But we did keep teaching for a long time. And we taught. We've on and off, we've taken a couple of years off here and there. But most of the time now we teach so that our kids will have peers to play with, because the social part of Irish music is what gets kids to practice. The performance part, the fun part in the pubs, sitting having a session with their friends. Next weekend or next month, we are going to our first, what we call FLA, which is an Irish word, and it's a competition for Irish music. And we have one in the Midwest, and we are going to that. So we stay in a hotel for the weekend. The kids will play in competitions. We are going to play in a trio with my daughter, and we always have a senior Keeley band, which is a group of 10 of us that we do. It's loads of fun. In fact, the text just went out today, and we do it for the fun. And this year, we're actually going to get to go to the final. That's the qualifier, but we're going to the final in August in Ireland too, for the first time for me in like 10 years.
Wow.
So that's the fun part of my life. And because my husband and I met through Irish music, and it still is the most favorite thing we do, we have tried to pass it on to our kids. And that's the big reason I'm still teaching, because my 2 youngest kids are in the grit class that I take. They're 13 and 11. And so their peers are learning with them. And we just organized a bunch of St. Patrick's Day gigs where they went and played for the school. We played for the senior luncheon, and they just loved it. And the seniors, of course, loved it. And that's the stuff life is made of. It's just, it gives me, it's just like medicine. It's like helping a patient. Playing music for people is just such a gift that we have, and we're trying to let our kids have that gift too. So it's sometimes hard to fit it all in, but we have managed thus far to make it work.
Amazing. So as we close, Dr. Ryan, can you please share any valuable resources that you've found on your life journey and your DPC journey that others should know about as they're exploring how to make their life balanced while thinking about DPC?
Yeah, so I would say there's a few different things to say here. Number one is, as a teacher of medical students and residents, and I know you have a lot of both who listen to your podcast, start early and keep thinking about it, even if you're in a busy rotation. Maybe if you get a lighter rotation, start thinking, start dreaming and educating yourself. And maybe you won't do it for 5-10 years, but at least you'll know how to do it when you do. Make connections. Social media for sure. Facebook, Instagram, and Twitter are great places to make connections with DPC. Follow DPC docs on those social medias, and join what groups that you can, chat groups online, etc. I feel like that was where I learned a lot of what I needed to know, and met the people that I needed more from, that gave me their time. That's how I connected with them, was to message them through social media. One of the big things I think for me was I didn't know how to run a business. So I joined the business association, and I met some really cool people that weren't doctors or DPC doctors that have stayed friends, and some of them have become patients. And I've learned a lot from that. And I feel like I'm still learning. I still feel like I'm very much a newcomer when it comes to business. I feel like I started so fast that I'm still learning. I'm trying to streamline it for sure. And then DPC Alliance has built a bunch of resources. That's part of my job description with the board. I'm actually currently building a mastermind handbook. So for people who have gone to a mastermind, or want to go to a mastermind, or want to host a mastermind, it's what I'm building as a host handbook, because I hosted my first mastermind in October of last year. I'm doing my second DPC mastermind in the Grange area as well this October. But I wanted to have it all in one place, all the resources for that. So DPC Alliance has a bunch for new docs and beyond. And then, keep up with the social media and reach out to somebody if you've got any DPC docs close to you. That personal connection, I think, is the most important. Although the only one I did have at the time was Dr. Sheetal, and she gave me freely of her time, but we have a lot more now, and we're trying to, stay in touch. The camaraderie in the DPC community, I think, is what makes all the grind of the business running, etc., worth it. It's so nice to be free and to have our freedom and control over our own destiny, and to share that with others. So those are the other, I think for the people who want to succeed, they will come to me most of the time. They've done a lot of this already. I usually give that feedback to people who, call me about DPC. When I see that they've already been reading, etc., I think that's the sign of success, is that you immerse yourself in it without needing somebody to hold your hand every step of the way. Because there's so many free resources, including your wonderful podcast.
Thank you, Dr. Ryan, and thank you so much for joining us today.
Thank you very much. Have a great day.
Next week, look forward to hearing from the founders of Direct Care Physicians of Pittsburgh, Dr. Natalie Gentili and Dr. Kirsten Lynn in Pittsburgh, Pennsylvania. For those of you who cannot wait to attend the DPC Summit in Kansas City, registration is live at dpcsummit.org. If you're on the fence about going to the DPC Summit, take a listen to the episode released earlier this week. And, in preparation for the DPC Summit, tune into the stories of the physicians who will be presenting. Hear physicians like Dr. Thomas White in Cherryville, North Carolina, Dr. Kissy Blackwell in Wichita Falls, Texas, Dr. Jack Forbush in Hamden, Maine, Dr. Amber Beckenhauer in Blair, Nebraska, Dr. Anand Mehta in Marietta, Georgia, and Dr. Vance Lassie in Holton, Kansas. Head on over to mydpcstory.com to find all their stories and get even more details about the summit. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear about DPC. Leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find all these DPC stories. And lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC in the meantime, check out dpcnews.com. Until next week, this is Marielle Conception.